Clinical examination of the central nervous system, visual fields. To test for visual fields, you sit 2 feet away from the patient. Then you move the hand in a plane 1 foot from both of you. So you are testing the patient's visual field against your own visual field, which is assumed to be normal. The patient is first asked to fix his eyes on the bridge of the examiner's nose, and then the examiner fixes his eyes on the bridge of the patient's nose. With the patient's right eye closed and the examiner's left eye closed, you test his visual field against the examiner's right visual field. This is done by moving the hand in a plane 1 foot from both of you. So you start with the finger far away, out of the vision of both of you, and the patient should indicate the first time he sees the finger out of the corner of his field of vision. So one should move the finger from each of the 4 peripheral quadrants of the visual fields, as well as diagonally. You can aid the patient by moving the finger, which then becomes easy to see. So asking the patient if he can detect the movement of the finger. In this way, a homonymous field detect can be excluded. So now, using the same method, you compare the patient's right field of vision against the examiner's left field of vision, and this confrontation method has the advantage that the patient's attention and also visual fixation can be assessed throughout the procedure. So with both eyes opened, simultaneous movement of the finger in the periphery of eye and left fields will exclude visual attention defect. Then use the same method on one eye separately with the other eye closed to exclude the monocular peripheral visual field defect. The central visual field and the blind spots has to be tested using colored hat pin, and traditionally red pin head 4 millimeters in diameter is used. With one eye covered and the patient fixating on the examiner's eye, the pin head is moved in such a way that the patient can report the area affected by the blind spot. So you compare the size and the shape of the blind spot with that of the patient, and in the normal, the two should precisely coincide. So using the red pinhead, abnormal defects in the central visual field of each eye can be separately slotted. And remember that the patient's field of vision is a lateral inversion of the examiner's field of vision. So this could result total loss of vision in one eye due to a lesion of the optic nerve could be elicited, and also it could be bitemporal hemianopia due to compression of the optic chiasma. The quadrants are usually first affected. Left homonymous hemianopia from a lesion of the optic tract could be present. An upper left quadrant or quadratic hemianopia from a lesion of the lower fibers of the optic radiation in the temporal lobe could be present. Less commonly, a lower quadratic hemianopia occurs from a lesion of the upper fibers of the optic radiation in the anterior part of the parietal lobe. Also, left homonymous hemianopia with sparing of the macula from a lesion of the optic radiation in the posterior part of the parietal lobe could be present too. If any serious abnormality is found, and the patient must be referred immediately to the eye department for detailed examination of the visual fields using tangent, Jerome screen, and a perimeter for testing the visual fields.